I will go more in depth on the topics that I have discussed yesterday when comparing the clinical trials, 3 and 2 drug therapies. So this time I will focus more on the clinical practice data, so more data on prospective or cohort study as compared to RCTs, and I will try to address some issues that were raised during the discussion yesterday. First of all, the long-term follow-up of these reduced drug regimens. I will talk just about 2 drug regimens, and I will avoid to talk of monotherapy, which is finished. And also, I will try to address the issue of resistance with 2 drug regimens. So with the effect of previous resistance and the selection of resistance at failure of 2 drug regimens. And also try to put some focus on other outcomes which have deserved a substantial attention during recent years with standard tribal therapy, but which have not yet been addressed so in depth with dual therapies. But there is some data, and I will try to present on the other outcomes such as HIV DNA and inflammation and central nervous system efficacy and so on. So first of all, these are data from the ICONA cohort. This has been shown by Carlo Federico as well. So all what we know is that most of our patients are nowadays suppressed, so it's not a problem to get virological suppression, but the problem is to maintain this virological suppression over the years. And for doing that, you see that in the Italian clinical practice, the use of dual therapy has gone up. So it's something that during the recent years is increasingly being used, still in a minority of patients, but it's increasing. It's increasing. And as you can see, just listed the most used dual or monotherapy regimens in the ICONA cohort. This was last year. Something may have changed during the more recent months, obviously. But as you see, darunavir is mostly used in dual therapies or monotherapy, but in dual therapies with raltegravir or with 3TC, and atazatamvir mostly with 3TC. And this thanks also to the data of the trials, but also dolutegravir is mostly used with 3TC in dual regimens in Italy, less so with rilpivirine, despite there were yet more data with rilpivirine, dolutegravir. And the reason why in the clinical practice in Italy now the first-line regimens are changed during more recent years, it's obviously no more mostly because of virological failure. This is stable over time during more recent years. But as you see, also toxicity is going down as a reason, and while simplification as a simple reason, simplification may mean reduced pill burden or reduced drug burden, is becoming more and more relevant. We know that in the naive patients, I already discussed yesterday, we have very few trials that were really working. There were 2 trials, not very good regimens for us today in this trial. We eagerly await, obviously, as discussed this morning, the results from the dolutegravir 3TC of the Gemini, which will be presented in next month. So to see whether this will change our picture, but several regimens in first line, several dual regimens in first line have failed. And you can see that most of these were a combination of PIs plus Moraviroc or PIs plus raltegravir. So they are really clearly inferior, select for more resistance, but they are not good. We know this now. Whereas in maintenance, what has happened over the time? First, we have at least 5 randomized clinical trials showing that boosted PIs plus 3TC, the green ones, work. they are at least non-inferior to their comparator. These are all large trials, so in the total is more than 1,300 patients randomized in these studies. Then we have smaller studies for PIs plus NNRTIs, which show non-inferiority, but these are really small studies. We have larger studies that show inferiority in the switch context of boosted PIs plus Maraviroc, which really does not work in dual therapy regimens and should not be used anymore in dual therapies. Well, all these are trials that other combinations, including integrase inhibitors plus X. And of these, you see, we have different sizes. There's a SWORD, which we discussed yesterday, which is the largest one and shows non-inferiority of dolutegravir-rilpivirine. But you see that in smaller studies, we have some non-inferiority, but also inferiority, again, in the switched context of atazanavir plus, so boosted PI plus raltegravir, which does not seem to work very well as well. Then we have different studies, some uncontrolled, a small study controlled is the ASPIRE with the dolutegravir 3TC in the switch. But what about the long-term follow-up of dual therapy? Well, still we have not very long follow-up. We presented a couple of years ago the 3 years outcome of the pilot study of ATLAS. This was the study was needed just as a proof of concept, and we showed that this combination atazanavir 3TC was working just 40 patients. But we followed these 40 patients for 3 years, and we had just 2 virological failures without drug resistance. So this is the longest prospective follow-up we have with a dual therapy regimen. Then we have the 2 years outcome of the randomized ATLAS study, which was recently published. And here again, we show not only non-inferiority of atazanavir 3TC as compared to atazanavir 2 plus Tonux, but even the superiority, which was mostly due to the fact that in the triple therapy there were more discontinuations. And again, in these 2 years, we show that the renal function improves in the dual therapy arm as compared to the triple therapy arms, which is clearly an effect of the interruption of TDF, which is particularly toxic in the context of the third drug being atazanavir, boosted atazanavir. And also the bone goes better with an increase, a significant improvement in the lumbar spine bone mineral density in the dual therapy arm as compared to the triple therapy arm. So what about the resistance? So are we sure that, because we've seen data from this trial, so where we did not really detect much drug resistance at failure with combinations of dolutegravir-rilpivirine or boosted PIs plus 3TC or even dolutegravir 3TC. So I want to show you the data which were presented last autumn at the EACS by the French and the Italian group in collaboration. They studied 465 patients with virological failure. 300 were failing a standard triple therapy, and they were split 1/3, 1/3, 1/3 based on the third agent, which was a PI, an NNRTI, or an integrase inhibitor. And they also collected 165 failures with dual therapies, and which were either dolutegravir-based or raltegravir-based, or based on a boosted PI plus 3TC. So importantly, none of these patients had failed to drugs of these classes in their therapeutical history. But this was a retrospective study, so the safety of this datum, the reliability of this datum in a retrospective study is not complete, obviously. So they tested for resistance at failure these patients, And what happened, these are the triple regimen, these are the dual regimen. In general, you can see that in the dual regimen, at failure, there is more resistance. It's quite clear. Well, apart from the regimen composed of nuke plus non-nukes, which has more resistance mutations as triple therapy, which is well known, but the others have less resistance as compared to the dual therapy failures. But when looking more in detail to the dual therapy failures, you can see that they have, for example, an interesting group of dolutegravir plus either rilpivirine or 3TC, and they have resistance to rilpivirine in this case, so NNRTIs, and they have 3 cases of M184V selection in this other case, but no resistance to dolutegravir, importantly. And then they have the other groups with boosted PI, or raltegravir plus etravir, and here we have resistance. This is expected already from the clinical trials and from our clinical practice. And finally, they have the groups of dolutegravir plus boosted PI, and here they have some resistance to both classes, even to the dolutegravir in one case. But here we don't know exactly, because when you give this regimen to patients, usually these are heavily pre-exposed patients receiving dolutegravir plus either darunavir or, in some cases, atazanavir. And finally, in the group of boosted PIs plus 3TC, contrary to clinical trials not showing resistance at failure, here in the clinical practice, we see resistance both to PIs in 20% of the cases, and in a small number to 3TC. Or maybe this is the opposite, probably. Okay. So the same happened in other studies made in Italy. This has been made in the ARCA cohort, and here we analyzed the efficacy, or in the real world practice, of the switch to darunavir or atazanavir plus 3TC, and we did not detect any difference between the two arms, although this is observational, so not randomized. But in this group, we find also patients with previous resistance. And as you can see, counting the cumulative drug resistance, particularly in patients with cumulative drug resistance to 3 classes, which is the brown curve, you see the higher probability of virological failure, even with 2. But interestingly, if you have no resistance or resistance to just 1 class, you see the same rate of virological failure. It's very low at 2 years. And also we observe 2 cases with selection of, one case of in which we have, with atazanavir 3TC, we have selection of both resistance to PIs and to the 3TC. Although this was a patient with previous resistance to nucleoside analogues and non-nukes, and probably this was a patient also with M184V, but was not detected before. So we have seen these data yesterday, so I will be very quick on that. This is another Italian group in Milan, and showing, as you may recall yesterday, that at failure of dolutegravir plus 3TC or rilpivirine, they had 1 case in which there were nucleoside analogues mutations, TAMS and M184V. Here there was not a previous resistance genotype with dolutegravir 3TC. And we have also these cases. The first one was the worst, actually, because in this case we had resistance prior to and after failure to dolutegravir rilpivirine. These patients should have never been put on this regimen because he already had resistance to rilpivirine, or she, I don't know, and with much more resistance selection during failure, and including dolutegravir resistance, so extensive dolutegravir resistance accumulation. And also, in this other case, on the contrary, there is not a selection of dolutegravir resistance, and the M184V, which was present before, becomes so a mixture. So probably this case was failing due to lack of adherence or something like that, presumably. With dolutegravir 3TC, we already know from the naive population of this pilot study, the ACTG 5353, which studied about 120 patients in first line with a viral load below 500,000 copies. This was preliminary to the Gemini studies, so pilot study. And they had 3 virological failure out of about 120, and one of these, this one, selected resistance to dolutegravir and to 3TC. And this was really a non-adherent patient with fluctuating levels of dolutegravir up and down, which finally selects resistance. So this is something very rare with triple therapy and dolutegravir, but it's something that may occur. We will see better in the Gemini studies with which frequency this will occur, but it may occur in non-adherent patients. So last year we presented this data here and then at CROI on the effect of the previous M184V selection on the efficacy of the regimens containing 3TC plus either a boosted PI or dolutegravir. And we studied about 450 patients. 87 of these had a previous M184V. Interestingly, the 2 groups with or without previous M184V were different in several aspects. So those with M184V had more extensive exposure to drugs, a longer exposure to drug, more previous failures. But they were suppressed for a longer time. They were suppressed for a median of 6.6 years as compared to 3 years, those without M184V. And again, also, interestingly, those with M184V, they had a higher frequency of resistance also to the PI component, 34% as compared to 4% without M184V. And this compromised the activity of the GSS, genotypic susceptibility score, of the drug accompanying 3TC, so either PI or, which was not the case for integrase inhibitor because there was no resistance to integrase inhibitor, just to boosted PIs. So overall, the outcome was similar with or without M184V, which is important to know. But interestingly, interesting is this figure. So we tried then to dissect all these patients with or without M184V based on the duration of the virological suppression. So when M184V was absent, independently from the duration of virological suppression, the probability of maintaining virological suppression was very similar. These are the 3 groups without M184V, with a duration of virological suppression of less than 3 years or less than 6.6 years, or the whole group, no change. Whereas in the M184V group, the duration of virological suppression counted, was important in influencing the virological outcome. Because here you see the whole group with M184V. This is the group with M184V, but with less than 6 years of virological suppression, and this with less, the yellow curve, with less than 3 years virological suppression. You see the difference here. So there is a signal, and at the same time we observe more viral blips in patients with M184V as compared to the others. But when we look at the multivariable analysis, which were the factors associated with virological failure, M184V was not. Duration of virological suppression was not. But the best predictor was the activity, so the GSS, of the accompanying drug. So when the activity of the accompanying drug was compromised, this was the strongest predictor of virological failure, as well as the peak viral load in the treatment history was associated with the probability of virological failure, which is something that comes back in different observational studies, including those with triple therapy. So what does it mean for dolutegravir 3TC? We will see, because this obviously influences the outcome of PI plus PTC. Let's see what will happen with dolutegravir 3TC. Dolutegravir 3TC, there are several studies. While we wait for the Gemini and the Tango, we have a randomized study which was shown yesterday. We have a larger but not controlled study, which is the Lamidol, showing in the switch context that the efficacy of maintenance therapy with dolutegravir 3TC was very high. In 100 cases, there was just one virological failure and no resistance selection. This is an observational study made in Italy by several groups of 216 patients switching to dolutegravir 3TC. This is a very clean cohort, so all switching from triple therapy, nobody with previous M184V, all HBs antigen negative. They have 0 failures over a median follow-up of 2 years. And as you can see, they also went more in depth with virological suppression, and from baseline 2 months 24, the proportion with not amplifiable HIV RNA remains the same under this regimen. And also our cohort in also a multicenter study, which is called Odoacrin, of 206 patients, which were just recently published on HIV Medicine, but these more details out of this cohort. We had, in over a median follow-up of 13 months, we had 5 virological failures, which makes 2.3 per 100 patients here of follow-up. And so the probability of virological suppression at 96 weeks was 95%. But in the subgroup of patients with a high peak viral load, higher than 500,000 copies, again, as discussed previously, we had a higher rate of virological failure. And you see the 96 weeks probability of remaining suppressed was 87%, so much less than the overall group. And this was significantly different. Of these 5 failures, 2 were clearly non-adherent patients. We don't have the genotypes of this patient. They resuppressed all under triple therapy. Another one had a long history of disease in ART, had a single viral rebound with immediate resuppression using the same regimen, dolutegravir 3TC, and no resistance mutation at genotype. Then we have another 2 with long history, one with previous M184V, and they all resuppressed under triple therapy or under a different dual therapy with atazanavir dolutegravir in this case. So it seems overall that really RT inhibitors in dual combinations are necessary. It seems they are necessary. The best results we have with combinations, including this regimen, these 2 classes of drugs. But differently within these 2 classes, between these 2 classes, that NRTIs we know work when they are fully active. If you have resistance selection, the activity is really lost. We know very well. And this occurs also in the context of dual therapy. With NRTIs, there is still some residual activity despite resistance. We've seen it for the M184V history. This is clear. We have seen it here. I also already showed this yesterday, but I want you to focus more on this arm of the study. This is where I recall you patients failing a first-line regimen in developing countries with 2 nukes and a nuke, so extensive resistance to nukes at failure. And one of the arms included a boosted PI monotherapy, which in this arm went clearly worse. At 96 weeks, patients in this arm were given 2 nukes. And these 2 nukes were mostly the virus was mostly resistant to nukes. And you see how they go up. The proportion of virological suppression goes up. So there is residual activity of nukes. This is a clear signal, also in this case. So, and I would like to end up with some data on different outcomes. One of these is HIV DNA. So there are very few studies on HIV DNA with dual therapies. We did this in the Atlas M study, in the randomized study. We had a subgroup of 140 patients which had baseline and 96 weeks HIV DNA measured. And as you can see, in the 2 arms, the dual therapy and the triple therapy arm, they had similar values at baseline. They had similar values at 96 weeks. And there was no difference between groups. Both declined a little bit, which is compatible with the fact that patients in the Atlas M trials were randomized after a median of 2.5 years being on antiretroviral therapy. And as you know, the plateau of HIV DNA is mostly reached after 4 years. So they still had some margin of reduction, and they reduced both in both arms in the same way, in the dual therapy and in the triple therapy arm. Neurocognitive performance. We know that there were previous reports, particularly in monotherapy studies, showing that there were virological escapes in the CNS which were linked to symptoms, which were symptomatic. In this case, in the Atlas M, we could not do the lumbar punctures, but we measured the neuropsychological performance over the 96 weeks, and we show that there is absolutely no difference between the 2 arms, dual therapy and triple therapy. And finally, we made also some longitudinal comparison in the same trial of the biomarkers of inflammation, coagulation, and monocyte activation. And we find that there is no significant change of C-reactive protein over 96 weeks, over 48 weeks, interleukin-6, soluble CD14, and D-dimer within or between arms. So absolutely no difference. The same is observed in an annex to the SWORD trial published on The Lancet. So no difference between the triple therapy and the dual therapy arms in these biomarkers. So we have the most solid evidence of efficacy in maintenance therapy with dual therapy as of today, expecting the Gemini results, particularly with PI and 3TC, or dolutegravir and rilpivirine. We see how NRTIs are required in these dual regimens. Still, we have problems with PIs because PIs have more issues and tolerability. So why to go to a dual therapy arms in order to reduce toxicity if you stay on a boosted PI, which is clearly more toxic? So we need the studies with integrase inhibitors. We have seen some toxicity, some benefit in toxicity of dual over triple, particularly in bone and kidney, but this is due to TDF discontinuation. What about TAF? If we have TAF, do we need this or not? There is reduced cost, but not for all duals. Clearly for 3TC-based duals, there is reduced cost because 3TC is generic and costs in Italy 50 cents per day, which is nothing. And so we wait for the WHO results, Gemini and Tango and so on. I think that for today, the candidates to dual therapy should not have resistance or failure to drugs or to classes used in the dual combination. We should carefully select them. And still, the forgiveness of these dual therapy regimens needs to be clarified and elucidated in the future. Thank you for your attention.